Okay, hello everyone. My name is Nikhil, and we are live today with Dr. Kayal from. She is a consultant in Astra CMI Bangalore Hospital, and she is an expert in intestinal ultrasound, which is the discussing today. Right now, we're streaming live on the YouTube channel of Crohn's and Colitis Squad, which is an initiative of the IBD Patient Support Foundation India. And today we are going to be discussing a topic called intestinal ultrasound. Just a few lines about the ultrasound. This is not the typical ultrasound that we get usually in the clinics. The ultrasound that you usually get in the clinic to capture as much, too many features of the intestine that a doctor can use to assess your IBD. But this is a new technique that has been developed, this new technology, which is, being very popular around the world. And Dr. Kayal will tell us things about how about this new technique and how it can benefit the patients. And after, she'll be giving a short presentation. After the presentation, we'll be asking a lot of questions to her. Yeah, thank you, Dr. Kayal, for giving us this presentation today and joining us and agreeing to share your sharing your knowledge and answering our questions for us. So yeah, over to you.
Yeah, thank you, Nikhil. Thank you for the kind invite. It is in fact a pleasure for me to be a part of this Crohn's and Colitis squad that you have. I think it's very important because we all know that Crohn's disease is a long-term disease. If you have interaction with other patients who are suffering from it, probably gives you a lot of positivity to push yourself forward, because treating IBD patients, I know that what each of them go through at every phase. It's not only the disease that we manage, they become close friends with me, and we also discuss their family lives, their personal lives, and how they have to deal with all this and yet succeed very well at whatever they are doing. So I think it's important, and you're doing a wonderful job at this.
Thank you.
Yeah. So let us, shall I start off my presentation? A short presentation on intestine ultrasound. I think you need to allow me to share my screen. I'm not able to share my screen. Maybe you need to allow me to share my screen.
Okay.
Thank you. Yeah, that's done now.
Okay.
Thank you. So let's discuss about intestinal ultrasound and IBD. We all know what the targets are for IBD. This is what we call as a stride consensus. If you attend any doctor's meeting with IBD, this is what we will find. Everybody will be talking about the stride consensus. Basically, what we see is every time we achieve one target, we move on to the next target. And we've clearly found that higher the targets that we reach, the patient's response is better and their relapse rates come down. So a first target when we start medications, I want to know whether the patient is feeling good. If the patient says, doctor, I'm feeling good, that is a good point for me because that is symptomatic response. Next, I tell him, see, I know you're feeling good, but I want to know whether the ulcers there have healed, whether healing has occurred. That is why we look at other markers like CRP or a fecal calprotectin, which is a stool test where we assess. And the ultimate healing would, at this point, what we're looking is endoscopic healing. That means the ulcers which were seen previously, after starting treatment, have healed. This is the last target that we achieve. But because we know this is the maximum that we can reach, is there something beyond this target that we can reach? If you look at this arrow here, it says transmural healing. Trust me, if we can achieve that, then we've done the best. So the first target is good, better, and this is the best. So we keep increasing. So that's how when we call back our patients and tell after 3 months and tell them, I want to check your CRP, fecal calprotectin, like doctor, test again. But it is important that we achieve those targets. That will ensure you a good quality of life all through. Now, to achieve these targets, I told you there are various tests. Most important is how you are feeling. That is our first target. And once you're feeling good, we try and achieve the other targets. So what are the targets that I use? Right now, what is available? We have colonoscopy, a CT scan or an MRI scan. We do fecal calprotectin, which is the stool test, and a blood test called CRP. If all these look okay, I know you're in remission and you're doing a good job, your disease has responded well. So I say, continue the medication. You're doing fine. And after some time, I want to check if everything is fine. So if I say another colonoscopy, all my patients do this. Of course, it is a very, very difficult thing to undergo. Colonoscopy is traumatic. I totally understand. But I agree with advancements in technology and sedation that we use for all our patients. It is less traumatic, but nevertheless, the preparation, the whole process, I can totally understand it from a patient's point of view. The next thing I say is a CT scan or an MRI scan. Well, it comes, one thing, CT scan comes with a lot of radiation. Once, it's okay. Twice is okay. I keep on repeating CT scans. It is a lot of radiation to you. And also, they're expensive. CT scan and MRI scan, to keep doing it again and again is expensive for the patient. So is fecal calprotectin a good test? Now, I say fecal calprotectin means that you have to collect the stool sample and come and give it to me. So that itself is tedious for a lot of people. It's not easy to collect a stool sample and get it for testing. And of course, the test has some limitations. It can be falsely normal, it can be falsely abnormal. Even if you have somebody has a regular infection like eating out food outside and they have a diarrhea, and if I check their stool test, they can have elevated calprotectin. Now, is this elevation because of that or is it because of IBD? These are things that we need to look into. CRP is a good test, but remember, if you have any infection, even if you have a cold, CRP levels will be high. So it is the doctor's duty to try and balance. Is it because of IBD or not? So all these tests have some limitations. And of course, the invasiveness with the colonoscopy or the radiation or expense with the CT or an MRI scan. So I must tell you, if you're suffering from IBD, you must be a rich person to be suffering from the disease because it is an expensive disease. It is an expensive disease. You have to spend a lot to keep your disease under control. And with our healthcare system, where it is mostly private healthcare and not the government healthcare, it is a big burden for the patients and their family. It is difficult. So can we overcome all this? Is there something we can have in addition to all this, which will help us get the same information? And that is where intestinal ultrasound will help. So going back to what Nikhil was talking about, what is intestinal ultrasound? So you go to a radiologist. The regular ultrasound they look at the liver, spleen, pancreas, gallbladder, kidneys. In males, they look at prostate. In females, they will look at uterus. This is what a regular ultrasound comprises of. Now, what do we do in intestinal ultrasound? Which will be done by your gastroenterologist. He will look at what he wants to see. That is the intestines, where we focus specifically on the intestines. And it is time consuming. You need training for this. The regular radiologist will be doing so many ultrasounds per day, won't have the time for this. And they won't have the clinical knowledge that we have about you, the patient, to see whether it is there or not. So that is where intestinal ultrasound plays an important role. And I think a gastroenterologist doing will help it more. I will explain how. And if you look at intestinal ultrasound right now, Europe and Australia, they are going big about it. They're utilizing it in the day-to-day care of patients. It has just touched USA the last 1 year. Japan has been doing it for the last couple of years. And in our country, probably we are the only center doing it. And my aim with this talk, connecting with you people, is to promote it more, not out of any personal interest, more from the patient's point of view, because we need to follow it up. And I think my job right now is to spread knowledge to the patients and to the doctors and train them regarding this new technology, which will benefit our patients most. That is our ultimate aim of treating patients. If the patients are happy, I am happy. So what are the advantages of an intestinal ultrasound? One, it is non-invasive. When I say invasive, doing a colonoscopy is an invasive test. Ultrasound is not invasive. I just do a scan like a regular ultrasound. It is, of course, not expensive. There is no radiation involved. A lot of all our pregnant patients also, we keep scanning the ultrasound. So there is no radiation. It is safe. It is reproducible, meaning I can repeat it any number of times I want without expensive, and I can get reliable results. So a CT scan will have a limitation to the number of times we have to do because of the radiation. An ultrasound, I can do it every 3 months and monitor you and say, good, it is doing good. No, I'm finding some abnormality should be evaluated. No, you're doing good. All that I can discuss at that point. And this is what I do for my patients, at least what we've started doing in our unit, at least. The patient comes to the OPD. We ask the patient history. How are you doing? How are you feeling? Are your symptoms okay? Are you losing weight? What is the frequency of stools? Are you having pain? History we discuss. Then I examine the patient, feel for his pulse, look if he has anemia, feel his abdomen. Do I feel anything wrong? This is what we do. And of course, we all ask our patients to come with a blood test, which I will look. Doing all this, I scan as I'm talking to the patient and I show them the results. I say, see, previously, this was what your intestine looked like. Now, this is what it looks like. So all this, I'm doing it at once. So I have all the information on what. This is what we called as point of care. At one point, we are doing everything and getting all the information. And you don't need a separate radiology or ultrasound visit appointment. And you're able to see the results immediately. There is instant visualization. This is the advantage when we do it as a point of care. This is simple. I don't think you need any rocket science to understand it. This is one of our patients with ulcerative colitis came to me in June last year. This was his intestine. This definitely looks abnormal in comparison to this ultrasound picture in September, which is a very nice looking sigmoid colon. The picture on your right in September is a normal looking sigmoid colon. This is the same patient's sigmoid colon before treatment. That means you're just looking at the wall thickness. It has showed improvement. Patient is feeling better. Intestinal ultrasound is showing improvement. I'm happy for the patient. This is what we need to follow. But the next time the patient comes, I do the ultrasound and I say, it's looking good, man, don't worry. And if sometimes advantages, before patient starts developing symptoms, we can see abnormalities here, if at all an abnormality is likely to come. So looking at this, I can predict whether you will develop an abnormality or symptoms later. This is just a simple thing. And looking at this, I know you can also interpret it. It's that simple if you have the adequate training. Of course, there are some limitations. I'm not saying this is the only test. Obesity, very patients who are overweight with a very, with big tummies, it is of course difficult to assess the intestines, which are deep-seated. In the colon, if you see the rectum is the last part, that visualization is a little difficult with intestinal ultrasound, but the rest of it can be visualized reasonably well. And I think at this point, the challenge for us is adequate training in intestinal ultrasound, which we still lack in our country. I'm looking at developing this in the future. So, like when we have any invasion to our country, we have different forces to help us. We have the army, we have the navy, we have the air force. Like that, the gastroenterologist has various things in his kitty to treat patients and follow them up. It can be a colonoscopy, CRP, fecal calprotectin, CT scan, MRI scan. In addition, I think the new kid in the block, the sunshine there, is the intestinal ultrasound, which, like I discussed, is not expensive, low radiation, can be repeated any number of times, and of course, with an adequately skilled doctor. So when I'm saying this, I'm not saying only intestinal ultrasound is a solution and you don't need all this. You need all of this, but your doctor can choose what is appropriate for you instead of going in for non-invasive tests also. This is one more added to our armamentarium to help patients improve with their symptoms and lead a good quality of life. With this, I conclude, and I'm open to any questions from your end.
Thank you, ma'am. Thank you for the presentation. We definitely have a lot of questions. Just give me 1 minute to
Sure, definitely.
So, so basically, what all can be judged using this intestinal ultrasound? That would be my first question. I'm a patient with Crohn's disease, and you showed some, the bowel thickening and all. But whenever I'm very sick and also there are a lot of ulcers and now I have a fistula also. Can all these be tracked using an ultrasound?
Yes.
Because for a long time I have been avoiding, getting all this like, assessed because of again the CT thing and the endoscopy thing. There are a lot of other factors
Yes.
associated. So will this technique
Yes.
help in those situations also?
Yes, definitely. Especially the first time when we do it and we document it, we can use it for follow-up. I will be able to assess the bowel wall thickness, which will tell me whether ulcers are there or not. Okay, that is the first thing. Presence of ulcers, I can't see an ulcer, but that increasing of the thickness of the intestine is an indication that there is inflammation going on. And also we use other things like color Doppler, whether there is increased blood supply there because of the ulcers, other things like that. Fistula abscesses can also be assessed. Of course, when it comes to fistula and all, I agree. If I find it, it is definite. If I don't find it and we still have suspicions, I would recommend a CT or an MRI. So it all depends on whether I find it the first time. And we will be successful with it around 60 to 70%, 70% of the time. 30% of the time we will miss it on an ultrasound, at which time definitely a CT or an MRI will be necessary. But disease activity, whether you have active disease or not, can definitely be assessed on an ultrasound. And also when I follow, I can assess whether you responded to the
people
treatment.
who have like strictures?
Strictures that can definitely be picked up on ultrasound, can definitely be picked up. Yes.
Okay.
Yeah.
Okay. And also, so let's say like I'm on a biologic and like oftentimes, like again, like you said, like we do the blood test regularly, but then we are not sure whether like our symptoms improve. And mostly like we have to follow up in 3 months and then again do like a CT or a colonoscopy. So like all these things can be avoided with an ultrasound, or like is it helpful
Yes,
there also?
definitely,
Like,
definitely. That is what we're trying to aim. Like I told you, Nikhil is easy because you're thin. I can see your intestines very well, I'm sure, and I will be able to show you the abnormality and the improvement. An obese person, we may have some difficulty. So, like I said, we can assess the thickness, we can assess your response to therapy, strictures, fistulas, and if you have any complications like abscess, can be assessed and repeated. Colonoscopy to repeat or a CT or an MRI to repeat every 3 months is difficult, but an ultrasound can be done every 3 months, like your blood tests or your fecal calprotectin, and we can follow it up very well. So I think maybe if, and one more thing, what I noticed is our patients also are happier doing an ultrasound, whom I'm doing and I'm keeping on follow-up. They're happy and I show them also, see, this was the value the last time, this is the value this time. They're seeing it with their own eyes. When I explain it to them, they understand it really well. And they're able to, they appreciate it and it's comfortable for them.
Yeah, exactly. I think the like ultrasound is the only test which is like the most comfortable. Even a blood test like involves like pricking, right? So but in an ultrasound, and you have the technician usually is there and they can show you, and especially when they're cooperative, like when they talk to us, I think it feels a bit more helpful, and they can just tell us what is happening. And definitely. But yeah, some patients have also asked like what is the cost of this compared to the CT or the MR angiography?
Okay. This is in our country. Okay.
Let me be honest. A little higher?
Yeah, no. Until how much do you pay for a regular ultrasound? It varies anywhere between 2,000 to 5,000, and based on whichever center you're doing. Unfortunately, our the country has its variations based on the private hospitals, and that is something I have to admit. So anywhere between 2,000 to 5,000 is what you're spending. What they will charge will depend on the place that you get your ultrasound done. First of all, if the person is trained, and I think it should be less than that.
Okay. And lesser than a CT or MR though, right?
Definitely, yes. Your CT scan or MRI scan, nowhere will you get it less than 7,000, or because when you're doing it for IBD, you have to get the enterography protocol. Only then can you visualize the intestine. And when you say enterography, your costs are higher. They go anywhere between 8,000 to 10,000. And I think your intestinal ultrasound should be charged at the same rate as your ultrasound or less than that. This is my personal opinion. How much each person charges will be the thing, but this is my personal opinion.
Also, does it involve any contrast like the CT or MRI? Like also like sometimes we have to do even in the CT, like we have to do the preparation and also like
Yes.
an ultrasound. Do we have to come by fasting or something? Like what are those
No,
things that we
not
have to
recommended at all. I
take
don't
care of?
recommend my patients to come fasting. I don't recommend them to drink any liquids. When they come to my OPD, as to see in the OPD, whatever fast food state they are in, we do the ultrasound and we are able to change changes. So no injections, no oral contrast, no fasting also is necessary. If you're fasting, it'll help. But if you're not fasting, it does not cause any difficulty. You don't need to come with any preparation. Just walk in and we will do it. That is how intestinal ultrasound is made. You don't need any preparation.
And also, yeah, that is good. Also, like you said, that, like, I think like why I am excited about this is like perhaps this is the only thing like I've ever been excited about in the last 10 years of since I've ever had Crohn's disease, and even more excited than a drug, because usually what happens is some drug is created in the US and all, and it takes 5-10 years, then it comes down to us. But this is like the first thing which I am seeing is going in parallel, that they are also getting the option, and here also we have at least you that we have that thing available. So like how long do you see before like it is available, like widely available across the country, or at least in the major IBD centers, at least in the big hospitals that we go to? Like what is
Yeah,
the because right now, as you said, like it's just in your center, but so
yes,
then how do you see it spreading amongst
yes.
our doctors in India?
Now you're making me take up more responsibility on this, but I see it coming up in the near future. Hyderabad and AIG, along with the International Bowel Ultrasound Group, is organizing a meeting in November. So that will increase the awareness amongst the gastroenterologists. I've also been doing my part to increase awareness among the gastroenterologists for the last 6 months or so. Definitely it is coming. Subsequently, how each center utilizes it will depend on their thing. But if a gastroenterologist wants to get trained, I think 2 months training, if they have basic ultrasound skills, they should be able to do it. So I am hoping within the next year or two, we should have at least 10 people in the country. If one person spreads to 10 people, 10 people spread, each of them spread to 10 will turn into 100. So my target is at least 20 people in the next 1 year, so that we have 100 to 200 other doctors performing it. I think that is where I'm aiming at, but yeah, let's see how it goes.
Also, like you said, like, is this procedure only to be done by a like trained gastroenterologist, or like because I'm thinking like like the usual ultrasound, we go to the clinics and just do it, and we don't even know what the qualifications of technician are. We just trust that person, that okay, that person is doing an ultrasound and he knows. So
See,
like how is this
yeah, I think a gastroenterologist should use it at the same time to inform. If there's a radiologist who can do a good job and give me the information, I'm okay with it. But I think if a gastroenterologist does it, you have all the information when you come at the same time. Instead of going again, take a radiologist. And the radiologist won't have this clinical background. When I see a patient, okay, I know this is ulcerative colitis. These are just areas of involved. This is what I have to focus on. This is a patient with Crohn's disease. Now he's come with fever, pain. Is there an abscess? He's having vomiting. Is there a stricture? I have the clinical information. And if a radiologist will see, it looks okay, say, but for me, I will search for it because I know your clinical background. And I think that is where it will be better if a gastroenterologist does that than a radiologist. Not just a gastroenterologist, the doctor who's treating you should be able to do it. So in that case, you will search for the specific things that you're expecting, and you will put in more effort to find it than a radiologist who has another 20 patients waiting for him to do the scans.
Okay. And
so
will this help people with both?
It will benefit. I didn't get you. Sorry.
Okay. Yeah, so I am asking, like, will it help people with both, like, who have disease in small bowel, and also like people who have disease in like the colon?
Yes, definitely. Okay. Yes, both small and large bowel. Like I told you, only the rectum will be the difficult part, but the rest of the bowel loops can be assessed reasonably well.
Okay, okay. And can it also be used for a person who has a stoma? Like, because we have the ileoscopy usually, the people with the stoma.
Stoma.
So
Yeah,
is it,
stoma.
yeah,
Yes. What I find is if the stoma bag is there, that hinders me in assessing the area around the stoma.
yeah.
So generally, I remove the stoma and then do it. Presence of a stoma, the stoma
Okay,
bag
but
makes
it can be done like that
yes.
way.
Once you remove the stoma bag, then you can definitely do it. It's not a challenge.
Okay,
And even patients who had surgery and who don't have a stoma also, it's very easy to follow up. I can see the site where they have joined, see if there's any ulcerations there, thickening there, disease activity there. All those things can be assessed very well.
Okay. So even people with like who have resections or J pouches, they can also
be
tracked
assessed.
and
Yes, yes. J pouches, I will expect
and can it detect yeah, yeah.
J pouches, I will have a little reservation because usually it's done for patients with ulcerative colitis. So the large intestine is gone and the pouch is located where the rectum needs to be. So it will be challenging to assess a pouch.
Okay.
Definitely, it will be challenging. It will be difficult with an ultrasound. Yes.
Can it detect perforation, intestinal perforation?
Okay, let me be honest. If somebody has an intestinal perforation, ultrasound is not a test I will do. Intestinal perforation means you're coming to me, you are in a serious problem where you need a surgery. So I will feel your abdomen. That is my first test. When I feel your abdomen, I know you have a perforation or not. And the next immediate test that I will do is a simple X-ray of your abdomen. A simple X-ray of your abdomen will tell me whether you have a perforation or not. So perforation means you are in for serious trouble. Your feel of the abdomen and a simple X-ray abdomen should give me that information. I don't think we should play around with ultrasound also at that time because it is a serious problem. It is the decision whether you need to go for surgery today, tomorrow, day after. That decision has to be taken. So no ultrasounds for perforation is not recommended.
Okay. And also, what about obstructions and like pseudo obstructions where like people get things like ileus and actual obstruction also. So like, can it help in those things or like that also?
You're referring to patients with IBD or
IBD,
regular patients?
like without IBD only, yeah.
IBD, again, like I told you, and somebody with obstruction will have two things when they're coming to me. They will have pain and they have continuous vomiting. Again, feeling their abdomen and the stethoscope on the abdomen with an X-ray will give me the best information. If it is a complete obstruction. If it is a partial obstruction is when we call it a stricture. So that is, if you have a stricture which is not completely blocking, ultrasound is a good test. But if you have a complete obstruction, then at that time, again, examining the patient and an X-ray will give me more information than an ultrasound. But I can do an ultrasound to find where exactly those blocks are. It will definitely help.
Okay. Okay. And also, can it be used to aid diagnosis or like diagnosis, like this has no, like, can it help, decrease the time period of diagnosis or like, instead of endoscopy or a colonoscopy, can IBD be diagnosed just using this ultrasound?
No. First time somebody coming for diagnosis of IBD, I think I will do a colonoscopy. I don't think anybody can diagnose IBD without a colonoscopy. Definitely not. A colonoscopy is a must. I can do an ultrasound simultaneously, see the abnormality and later follow up whether it is improving. But for first diagnosis, for somebody with ulcerative colitis, only colonoscopy is enough. For somebody with Crohn's disease, first time diagnosis, colonoscopy, and also a CT or an MRI scan is a must.
Okay. And will this help just patients with IBD or like other patients with like, IBS or like similar conditions with other, like they can also benefit from this?
Yes. Often patients who come with intestinal pain who just come into the OPD, we're not sure whether we have to evaluate a lot is because it's IBS or we have to evaluate more this IBD. when they come to me with 2-3 months pain, then me or my colleagues or we send them to me and I do an ultrasound and I say, see, it's looking reasonably normal. Look at the blood test. Maybe you can just manage it conservatively. If I see any abnormality, then I alarm my colleagues. I say, no, there is something abnormal. Go ahead and evaluate further. So at that time, the initial screening of patients, it does help. But that is to rule in or rule out IBD. That's all. Management subsequently is based on the IBS protocol or the pain abdomen protocol, and IBD will be managed according to it. But at least the initial assessment, when I do it, I can say, look, his intestines or her intestines are fine. Wait, his or her intestines are abnormal. Evaluate further. That information I can give it to myself, patients, and to my other colleagues in my department.
And also, ma'am, like, let's say when it is more like widely available, can patients like usually just say like, we just go to the center and, we can like self order an ultrasound and they don't even check like whether it's like, prescribed by a doctor or something. So like, can patients like do that, or would you recommend people to, get it done only when the GI says it, or like,
Yes, see, IBD is a complex disease and the management is also very complex. And you need to be really intelligent to manage an IBD patient who's also very smart. So this is to be done only on the recommendation of your doctor, not just go like a routine health check, get a check. No, definitely not. It has to be on the recommendation of your doctor. And the doctor should also have a reasonable knowledge of your disease when they're doing it. So,
and one other question is this useful for pregnant women who have been diagnosed with IBD to like understand the disease during their trimesters?
This is the best test to do for them.
So like, can it do the both things in one device, or like you will have one normal ultrasound and one?
It's the same device, but we just have different probes. And I am not trained to do obstetric scans where you look at the growth of the baby. I'm not trained for that. I will only look at the intestines and come in. So there are many patients when they come to me and they say, doctor, intestines are okay. Look at my gallbladder, look at my liver. I'll say, see, I can look at it, but I think a radiologist is a better person. I'm focusing on your intestines. So even if it's a pregnant woman, that is the best thing. We have 2 of our patients women who are pregnant, and we are taking them through their pregnancy, and we're following up the disease activity only with the ultrasound, which is beautiful for them also.
Yeah.
And I don't talk to them about their babies at that.
Yeah. So it's like an upgrade to the machine.
Yes. Just
so it's like an upgrade to the machine, basically.
Yes.
Okay. I think that's all we have. So thank you, ma'am, for answering all of our questions, and we hope that we get access to this like very soon, and patients like all around the country can hopefully benefit from this. And as a patient, like I'm really excited about this. And you're right, the more intelligent the patient, like it's harder, because
I'm honest, after all the patients I see, I think
do these things that are not recommended.
Yes. Thank you. I'm really delighted to be a part of this group. I'm always available to all of you whenever you need any help. And I believe IBD patients are suffering more than any other form of disease. At least cancer, there is an endpoint. This is like diabetes, but diabetes or hypertension, you don't have as much suffering as you have with IBD. And so I know what you people go through, always there to support you. And I will do my best to spread this knowledge across the country to help all of you at different parts of the country. This is a good tool, but in conjunction with all the other tests. I don't want everyone to go back with the idea, I do an ultrasound, everything is fine. This is in conjunction with the other tools. We have another force with us to help us treat you and evaluate and manage you better. But it's been a delight. And I must tell you, of all the patients I see, IBD patients are the most intelligent. I don't know what is the correlation, but they're really intelligent.
I don't know, like even like for people with schizophrenia, they say like that. I don't know. Maybe like
difficult.
Our brains are like, compromise. They make a compromise, I think. Like for smartness, they compromise some other part of the body, and then
Yeah.
But definitely this will like, do you think like this will reduce the number of colonoscopies or endoscopies a patient will have to go through over the course of their disease?
Yes, definitely yes. And it will help in reaching our targets, like what I discussed earlier. So our targets is to benefit you. So once we reach those targets, we should decrease the amount. That is the idea.
Okay. Thank you, ma'am. Thank you so much for, talking to us and answering our questions for us. And yeah, thank you for all the work that you're doing with regards to the spreading of this technique everywhere in India. Yeah, thank you so much.
Thank you. And I must also thank my team for encouraging me to go through this. We have Dr. Naresh Bhatt, Dr. Amit, Dr. Anupama, Dr. Raghu. Dr. Raghu also does intestinal ultrasounds in my unit. They've been very supportive of this because for me to go to the training and come back, and we have a very good team also supporting us and the patients. So some of the patients I don't follow up, they follow up. They see them in the OPD. For them, I help them with the ultrasounds alone. So a good team is also essential to manage patients.
Also, ma'am, yeah, for patients in Bangalore, like how can they reach you or like, the other doctors?
You can come to,
give a little info,
I only practice as Aster CMI Hospital in Nepal. I don't practice anywhere else. And you can always come to a unit. If you don't get my appointment, no issues. You can meet any of my colleagues in my unit, any appointment. Dr. Naresh Bhatt is there and the rest of us, Dr. Anupama, Amit, Raghu and myself. You can meet any one of us. We also have a pediatric gastroenterologist. This is one more area I forgot to mention. In children, especially with repeated imaging and all, it's not good. Ultrasound is a brilliant modality. We also have a pediatric gastroenterologist with us. So just come meet any of my colleagues, and if you need an intestinal ultrasound, they will let me know, and either me or Dr. Raghu will do it.
Okay. Thank you, ma'am. Thank you for everything. Yeah, and we will definitely reach out to you for, if you have any more questions or anything.
Sure,
Thank
definitely.
you so much, ma'am. This was really a very informative session. I think a kind of ray of hope for we patients, because like many times I just keep postponing any of this endoscopies or anything. I think with this, like we also have more confidence to come to the doctor and get our status checks every once in a while. I think this hope to see you soon in the Aster CMI hospital.
Oh, thank you. Thank you so much. I think what I believe, or what two of my mentors believe, is knowledge is not knowledge if it's not spread. Yes. And I think this awareness of this technology, this knowledge not only has to reach the doctors, but also patient awareness has to improve. And I think Nikhil has played a very important role in doing this today. Very good job that you people are doing. And I think you need to, all of you need to stay together to help each other as well. You must continue this good work. And I'm always available to your squad at any point of time that you need any help.
Thank you. Yeah.